time to just change that.
You made it live.
Yeah.
चल रहा है. It's going on. Good evening, everyone. Welcome back. So today now we are at the last episode, that is the third episode of Clinical Aerobiology webinar series. In the past 2 days, we have learned about the basics of aerobiology, in which Dr. Divya has spoken about the basic principles of aerobiology, and especially the aerospora, about the production of aerospora, dispersal of aerospora, about the pollination calendar, pollen calendar, and then thereafter Dr. Mahesh spoke about the effect of pollution and how it increases the allergenicity of particular pollens in particular areas. Then yesterday we discussed, Dr. Narmada discussed about pollen calendars across the country. Dr. Taha spoke about Himalayan belt, so different pollens in the Himalayan belt, and then the clinical correlation was spoken by Dr. Nagendra Prasad. Now, during yesterday's conversation, there was some discussion which was happening about the cross reactivity. That means in one particular group, in one particular family, if you are checking one, two, three things, and then later on you find that, okay, these are cross reactive, you might need to check only one, or you might need to probably act on one. So today is a very important day in which we will be highlighting further more about this aspect of cross reactivity and what is the clinical correlation, and simultaneously how we can implement that in our practice. That means what should we test, how should we interpret, and how we should proceed further. And then at the last, we will also be speaking about or talking about pollen forecasting. That means can we do some preventive measures? And ultimately, at the last, we will be speaking about allergy smart communities, that how we can shift our community towards a allergy smart innovative idea. So with this, I would like to invite Dr. Soundarya. Dr. Soundarya is the leading pediatric allergy specialist at Mangalore Manipal Medical College. So Dr. Soundarya, please start.
Thank you, sir. So good evening, one and all. Today we are in the third concluding webinar. I thank Dr. Neeraj for giving us a small recap of what has happened in the last 2 days. So in today's webinar, we'll be concluding the triology series on the clinical aerobiology. Today's session comprises the clinical correlation, and we have three very eminent speakers for this. Our first speaker is Dr. Gayatri Pandit. Madam is an otorhinolaryngologist from Bengaluru, and she has done extensive work in allergic rhinitis, and she is one of the best speakers in discussing integrated clinical history and cross-reactivity in aerobiology. So welcome, madam. I kindly ask you to share your slides and take over the session.
Thank you. Thank you, Dr. Soundarya. Thanks for that introduction. Are the slides visible?
Yes, ma'am. Yes, thank you.
Okay, yeah, thanks. First of all, to begin with, I would like to congratulate IAP Allergy Chapter for initiating this topic, because this is not something which is, generally spoken about, but it is something very important for our day-to-day practice. What I will probably be talking is more from a clinical aerobiology perspective of it. So in the first day, you have, probably understood it from a botanical perspective of it. But when we start, or how much as an allergist that we should know aerobiology, or what aspect of the aerobiology that we should be knowing. So that's what that we are going to speak in the another 25 minutes time. And also the whole purpose of test here, the whole purpose of the presentation is that when you do a testing, it is to correlate whether whatever has come positive, is it a real sensitization or allergy? And the second thing is, if you consider this patient for immunotherapy, how do I choose immunotherapy depending on the cross reactivity? So this is what I'm going to discuss in another few minutes time. So I would like to tell that, first start being familiar with the allergenic plants. These are not the one which are there in the deep forest or something. They're just the road that we are walking. They're there in the just the park that you are walking every day. So start looking for them. And even when you are driving, when you are taking a vacation, just look into the flora and fauna of that particular area. See what is there. If you have gone out for your next vacation, you just look around and what different these area have a plant or a trees, and that will kind of inquisite the interest in you to know more and more about aerobiology. The other basic thing that you need to understand is about the cross reactivity, which we are going to take further, and how to take a second history. We often tell that take a second history, but what is that second history? How do we even take a second history? What does that really mean? Have we not taken the history already? Why is the second history, or what different it is from the second history, is what we are going to see in couple of cases also. Some other thing also that you should know, that the flora and fauna are well sunk with the nature. So that means that the trees uh, pollinates every year at the same time. Whether it is some festival, you relate it with some festival like Shivaratri or Ugadi, like Acacia fistula. Every time it blooms in the Vishu time for Kerala people. So it is well sync with the nature. But you should also know that though that we speak about the rough pollen calendar or a peak pollination time, it will also differ from the rains or the warmer climate. So you might have a longer pollination time sometimes depending on the rain. You might have a shorter pollination time, or you might have a pre-season sometimes depending on the rain, climatic condition, etc. So you should be little bit be aware on those things also. So when you deal with a patient, then let's go to a more and more of a clinical scenarios now. So when a patient presents to you, so first you have taken the history, and then you have decided to do a skin prick allergy test, and then you go back to second history. So through some of our cases, we will understand what is this second history is. So what all are important when you take a second history? So you will go back to the seasonality of the symptoms again. You will again ask about the diurnal variation of the symptoms. You will try to understand on the patient's surrounding more now, and patient's outdoor activity. Outdoor activity, what I mean is, what time is a patient going for a walk? Is a patient going for a jog? Where is he going for the jog? Might look like none of our business to a patient initially, but these things are very important. Sometimes even the indoor activity, which remains to be important while taking a second history. How is patient when patient is out of his town, or how was he when he was elsewhere? So what I often call it as a migration history, only that probably the allergy specialist will ask, or what are their near future plans from now. So these are something like a migration history also that you should include, especially with respect to pollen when you're taking a second history. So some very few cross reactivity. See, people think that the cross reactivity is a very huge, it is very difficult to understand. It is very complex. No, not at all. We have to just learn about some 4-5 things. That's all, and that's enough for our practice. At least I'm speaking from Indian context here. So the pollens which are coming from the same group of the species can have some amount of a cross reactivity. It doesn't mean that they're 100% cross reactive. Okay, so they can have a reasonable amount of a cross reactivity. So hence, either testing one of that or choosing one among them for the immunotherapy would be more than be sufficient. Now, for example, for a Poaceae family, now when it comes to grass, there is a one big family that you need to remember is that there is a Poaceae family. There are many other families like a Chloridaceae and all. But what, as an allergy specialist, and the most important family that we need to be bothered about is a Poaceae. So major grass pollens like a cynodon, cenchrus, cypress, so they all belong to a same family, and including a cultivating grass such as ziamis, like jowar. So the cultivated grass. So even that belongs to Poaceae family. So you could consider to test either one or two among these, depending on what is quite prevalent in your area of practice. Cynodon is prevalent everywhere. So I would prefer that the cynodon has to be tested, and the rest other two you will decide depending on what is more prevalent. The Asteraceae or the sunflower. Okay, so it is Asteraceae means it is a sunflower family. There are three very important pollens in sunflower family. One is a Parthenium, which is very common pan India, also called as a Congress grass. The second one, the spiny pigweed, also called as a Xanthium strumarium, and the mugwort. Now, Parthenium is common almost like a pan India, probably little more in South India. Xanthium is little more towards the village side, like when you go to the periphery from the town. That is where the xanthium is more prevalent. Mugwort is more in Himalayan and sub-Himalayan belts. The next weed family is a Amarantaceae family. So Amarantaceae family has two, again here, Amaranthus, sorry for the spelling mistake there. It's Amaranthus spinosus, which is nothing but like called as an mulharve in Kannada. It's also a green leafy vegetable that you eat. The other cross-reactive family is a Chenopodium. So in Chenopodium, you have a Chenopodium alba, Chenopodium murale. So all those things cross-reacts. The other important weed pollen, Ricinus communis, does not cross-react with any other weed pollen that we have mentioned here. The tree pollen, there are only two major tree cross-reactive families that you need to know. So Mimosae, which is coming from the Mimosa pudica. You know that the Mimosa pudica leaves, the touch me not, right? So the small leaves on the parallel venations kind of a thing. So if you see Prosopis julifera or the bubble tree, so the venations of the leaves are very similar to Mimosa pudica. So that's how that you can remember that it belongs to the Mimosae family. The other two, the lesser popular trees or the lesser sensitized trees are Albizia libic and also Acacia arabica. We don't have much of Acacia arabica in South, but you do have it in North India. This very next family of the tree, which is under the same big umbrella of the Mimosa, is a Cisalpinaceae, the two yellow color flowering trees, the Peltophorum and Cassia. So this is all the cross-reactive thing that you need to know. Because rest all don't cross-react. And when you choose allergens from immunotherapy, you will have to choose from these pollens when multiple things are there, one among these. Now, when many things are reacting under one family, how do you know that which allergen to choose for the allergen immunotherapy? So one which has given either a highest reaction, very dominant reactions with a wheel and flare with a pseudopodia, or which is relevant to your area of practice. Say, for example, if I have both amaranthus and chenopodium, which is present positive in my patient when I do a skin prick allergy test, and if amaranthus has given a reaction of 8 by 10 and the chenopodium has given the reaction of 6 by 6, so I would obviously choose the reactions which are more prominent. And if it has a pseudopodia and all, it also implies clinically little more to us. The second thing is, which is more relevant to my area of practice, which is more for me here, whether amaranthus is more, chenopodium is more. For me, amaranthus is more, but for somebody who is practicing in MP, Indore, Batua may be more for them, the chenopodium may be more for them, and they might consider chenopodium for the allergen immunotherapy. So it depends on two factors, which has given the highest reaction, and the second one is, which is very relevant to your area of practice. So one rough guideline on the though that you all can keep a pollen calendar and understand that which is a peak pollination time, what is pollinating now. Some very rough guidelines for you is the most grass pollens pollinate in a early summer, what we call it as an hay season. But in a warmer climate, it can pollinate perennially also. Most weed pollen, like a Parthenium, Amaranthus, Chenopodium, they are a perennial pollens but have a peak pollination time in monsoon. So you don't need to have a big rocket science for this. Even in fact, actually, if you just look around and you'll see that in monsoon time, all Partheniums have started flowering. Just observe them for 1 or 2 seasons and you know that. Ricinus communis, very, very classic winter pollination. And in Bangalore right now, it is pollinating. And if some patient is coming with history of runny nose, sneezing, intense eye itching has started since the last 1 month time. I was fairly good otherwise. I would straight away, think of Ricinus communis even when I'm doing a testing. So I will bet with my other residents, see that I'm going to get a Ricinus for this patient. So it's like that clear sometimes. So most tree pollens actually pollinate in the springtime. So that is between February to May is their peak pollination time. And they do have a second pollination time between August to October. But the most important pollination time for tree pollens are the springtime. So springtime is where you see all trees getting bloomed, isn't it? Very simple. So grass pollen around early summer, weed pollens mostly during monsoon, and Ricinus communis during winter, and most of the tree pollens during the spring time. So with this basic knowledge, let's move on to the case now. So you have a case, you have a 25-year-old techie presenting to you with a history of runny nose, sneezing since many years, and but which used to be mild initially. And last 9 months, symptoms have been more, and patient symptoms were worse from July. And symptoms are more in morning. Let's see what the skin prick allergy test tells. So skin prick allergy test, the patient has a good positive and negative control, and patient seems to be sensitized to Parthenium, Amaranthus, Chinopodium, and Cassia too. So let's see how to break this second history now. So how to narrow down our allergens if we consider this patient for allergen immunotherapy, and also to understand which allergen here is probably a sensitization and which allergen is for allergy. So what all are the second history that I'm going to revisit? Whether symptoms are more in the morning or evening? Yes, patient said that it is in the morning. So probably we do keep the pollens in mind now. The season, more in the monsoon time. So I will have to think for the pollens which are pollinating more in the monsoon in the list that I have now. When you ask about the symptoms, whether it's an indoor or outdoor, patient is telling that the symptoms are indoor. But our classic teaching has always been that the indoor allergens are dust mite, cockroach, and fungi, and outdoor allergen is a pollen. But this patient is telling that no, my symptoms are indoor. Then I ask him, do you feel better outside Bangalore? He tells yes. That means that I still keep a pollen in my mind. It may not be a dust mite which I have missed. So then I ask, where are your symptoms more? Indoor means, are your symptoms more at home? So he says, yes, my symptoms are more at home. When he tells that his symptoms are indoor, he meant that his symptoms are more at his home, at his place. But his symptoms are better even when he goes to his friend's house elsewhere. That means that the symptoms are actually not indoor, but symptoms are more at home. So what is happening at home? So then I asked him, so he's a techie. So now that post COVID, most of our techies have started working from home. So I asked him, so are you working from home? He says yes. So where do you sit? Where do you sit? Where is your office, desk in at home? So he tells that he's sitting next to a window near, in his bedroom. And I ask him, are there any lot of plants around or empty plots, or how is the place? So he tells that there are empty plots next to it, and probably that is where that the allergens from outdoor are coming indoor and presenting as an indoor symptom. So that's why sometimes the second history is tricky. So it is not as clear cut or as black and white that the indoor symptoms are because of these three allergens and outdoor is from pollens only. So ask some more questions in your second history when patient gives such tricky answers, and you will get your answer. So here probable allergen of culprit would be Parthenium, Amaranthus spinosum, and Chinopodium, right? So because all three are monsoon pollinating, and probably that, and this is the picture of the patient. And sometimes I often ask them to take a picture of their near surroundings. Go for your walk and take a couple of pictures and send it to me, or just send the nearby pictures of around your house. So this is the picture of Amaranthus spinosum, which is there in the plot very next to patient's house. Now, among these allergens, let's see if we can further narrow it down. Now, Parthenium, does it have any cross reactivity in the rest of the pollen? No, the Parthenium belongs to Astraceae family. Whereas Amaranthus spinosus and Chinopodium album both belongs to Amaranthaceae family. So we could choose one among that. So I chose to do Parthenium and Amaranthus spinosum for the allergen immunotherapy, because this is more prevalent and that's what the patient also has got the picture from. So the second case is a 43-year-old male who have been all well these years and started having runny nose and sneezing and itchy nose, and also has some facial itching and the conjunctivitis since last 2 months. Symptoms are very severe and bothering him, though that it has been for a shorter period of a time, and significantly affecting patient's quality of life, and symptoms are worse in the morning. And we do a skin prick allergy test, and I find that there is a significant sensitization for Ricinus communis, and to a certain extent very mildly sensitive to Cassia siamia also. It's a tree pollen. So now let's see what more that we ask this patient to understand that why that this patient started having a symptom now, or is it very relevant for this patient? Do we do any further things depending on that? So which time of the day? He has already told that it is in the morning hours. You ask him whether the symptoms are more outdoor and indoor. This patient tells that it starts outdoor, but the symptoms continues to be indoor for some more time, and it continues to bother sometimes the whole day also. So this patient was all well. So what might have happened? So I want to understand that what things have changed in the last 2 years. So I asked him what changes have happened in last 2 years in your lifestyle wise, in your location wise. So he tells, have you moved to a new location? Yes, he moved to a new location 2 years time. The last year he was perfectly fine, but this year has started bothering him. Probably because we also know that sometimes it takes two season of an exposure for somebody to develop a symptom. He tells that, yes, his symptoms have been since last 2 years. And what other lifestyle changes have changed in the last 2 years is that he started walking every day. He had got the yearly checkup done, and there were, he was found to have a high cholesterol levels. And that's why he started walking now. And he leaves his kid to school in the morning, and then he goes out for a walking around a lake for around 45 minutes time. And probably that is a place where he is getting exposure to this communist. So you ask him that it's a castor oil plant, and you show him the photos also. Do you think that these are there in the lake that where you are walking? Patient tells that not sure and probably not is what he tells, because he would never ever thought that this plant would be causing him a allergy. So he kind of not very sure or denies that this plant exposure being there for him. Now, the same patient revisits you after a month time, and he comes back and tells you that there are lots of castor plants around the place where he goes for a walk. And now that you have shown him a photo, now that you have educated him more on that, now that his eyes have started seeing that castor plant, which he never thought that those were the ones which were causing him an allergy. The second history again can be tricky sometimes, for the reason also that patient may not straight away identify the plant, and sometimes in your further subsequent visit is where patients start appreciating whatever the test that you have done and have counseled him on. Now, whether to take this patient for allergen immunotherapy or not, the patient's symptoms have been only for a 2 months time now, so maybe too early for somebody to decide for allergen immunotherapy. I would still tell that whether, no, I would go further one step ahead in my second history to ask whether that house is patient's own house or a rented house, whether he has an option of changing the house to a new locality where probably not too much of an exposure, or to avoid him to walk near the lakeside where he is going for, choose another area for the walking, and will do those alterations first before even deciding for allergen immunotherapy. So this is again, as I told you, I often ask my patients to get the photos, and this is the photo which patient got, and this is Ricinus communis. So the case 3, where we have a 10-year-old boy who was staying in Ahmedabad before and now has moved to Bangalore recently. And we quite often see in the metro cities that the patient keeps moving from one place to another, and either they shift here for a work or for their studies. And he had been having runny nose and sneezing and wheeze since last 3 years already, even in Ahmedabad. And he had a perennial symptoms, and his symptoms were throughout the year. And patient has been already using intranasal corticosteroid sprays. Patient has been already using ICS LABA also. But he has never got an allergy evaluation done in Ahmedabad, and now he comes for a first allergy evaluation he gets his first allergy evaluation done in Bangalore, and this is what his sensitization pattern is. So he's sensitized to dust mite, significantly sensitized to dust mite, also to pollens, Prosopis juliflora and Holoptilia integrifolia. So let's see what other second histories or what other important things that we need to know here. So symptoms are indoor and outdoor. He tells that he has both. So his symptoms are both indoor and outdoor. Any seasonal exacerbation, it's there throughout the year. Probably little more in a March, April time is what he is telling. Is it more in the morning time or a night time? Yes, definitely is more in the morning time. So with this brief second history, what is probably the culprit allergens are? Definitely indoor allergen is what you will consider for a younger boy. Perennial symptoms, more of a morning symptoms, you will consider dust mite. Probably, but how Prosopis julifera and Holoptilia is also contributing, especially when he came from Ahmedabad. So his Holoptilia sensitization has definitely occurred there, and his peak symptoms, which are matching both. Holoptilia has a peak pollination time around Feb-March time, and a Prosopis will be little later from March to little bit till the mid-May time. So it would match with whatever the symptom that the patient is telling now. So, but the patient is in Bangalore now. For me, what are the relevant allergens? Holoptilia patient's highest sensitization is for holoptilia, but for me in Bangalore, what is important now? So for me in Bangalore, HDM will remain the same, but Prosopis juliflora still remains to be important for us, but not so much on holoptilia. So we don't have much of a holoptilia down south here. So I will want to ask patient about what is the near future plan for the patient. So is he planning to relocate to Ahmedabad, or how long is his duration of stay in Bangalore, or any part in the north or the west part of India is he planning to go back? So if the patient has a plan to go back to north in some time, or if they have a plan to migrate there back, so then I would consider holoptilia also for allergen immunotherapy. So otherwise, my main allergen that I would consider for allergen immunotherapy from the second history knowledge that we have would be that the dust mite and the Prosopis juliflora. Okay. So the next case is a 12-year-old girl living in a green community in Bangalore. So there are quite, the gated communities are pretty popular in Bangalore, and they're kept very green. So she lives in one of the greener community and started having the symptoms of allergic rhinitis since last 3 years. But it has been progressive since last 1 year. And she tells that the symptoms are more in the morning and gets better as the day progresses. She does not have asthma, but she has a family history of asthma. Now, this is the sensitization pattern. So dust mite sensitization is also there, but seems to be, the sensitization pattern, if you see compared to a pollen, that seems to be a little more on the milder reaction. The Caseus iamia tree pollen is 8 by 8. Acacia arabica is 5 by 5. Neem is 6 by 6. Peltophorum is 6 by 8. So she seems to have been sensitized to many of the tree pollens. Weed and grasses are not there, so she's sensitized to many of the tree pollen. So let's ask about some more history for her. So whether the symptoms are perennial or seasonal, she tells that it is more from August to October. So that is kind of a second pollination time for a couple of the tree pollens which are there here. Symptoms are more in the morning or evening. She has already mentioned it as in morning. Does she gets up with a sneezing? She tells no, it starts little later after I get up. Usually dust mite, see when you have a dust mite sensitization also borderline and you also have a pollen, one crude method to differentiate from your history whether it is really a dust mite which is causing a morning symptoms or a pollen which is causing a morning symptoms. Most dust mite patients in bed immediately when they get up, so they start sneezing in bed itself. So do you get up and sneeze in the bed itself? Yes, it's more from dust mite. So if your sneezing starts little later, but in the morning itself, so you get up, you freshen up and then open the door, and then you have some fresh air, and that's when you start having the symptoms. That's little more of a pollen kind of a history. Is the acacia there in the community? So you show her the picture of the Acacia siami now after you have done the test. She tells that yes, there are some yellow flowering trees in our community, but I don't know whether it's the same tree or this thing. So then you know that probably this patient definitely has an exposure. So now that this patient, this is the tree pollen that she shows up, and yes, this is Acacia siamium. Now, Acacia siamia, Peltophorum, Acacia neem. So all these have certain amount of cross reactivity. As I told you, these two belongs to one Cisalpinaceae family. Acacia belongs to Mimosia but has a minor amount of a cross reactivity with the other two pollens. The neem, though it is sensitized, neem may not be a significant sensitizer. Neem is something which we call it as a mild sensitizer. It may not really cause lot of clinical symptoms unless otherwise, where the patient has a large amount of exposure of the neem, the neem pollen, like, very big, like a mini forest area where they do plant neem as in for the bordering of the village sometimes or the landscaping, and even as a part of a mini forest. Even in Bangalore, in some zones, they plant it as a mini forest. So unless patient has such amount of an exposure, neem may not be a major allergen that you would consider for allergen immunotherapy. So for this patient, Acacia and Peltophorum remains as important allergens to be considered for allergen immunotherapy. And acacia and neem, we would just be as a part of an pollen avoidance measure, we will be just focusing them and may not really consider for allergen immunotherapy. Few other mild sensitizers like neem are eucalyptus, Cocos nucifera, like the coconut tree, Acacia arabica also is a kind of a mild sensitizer, and a Casuarina equizonifilia in the coastal belts, especially for the west coast of India. There are a lot of Casuarina tree, but is a mild sensitizer, not a very strong sensitizer. So allergen to consider for this particular patient is Acacia and Peltophorum. And you know that the both belong to a same family. So one of them can be considered for allergen immunotherapy. So just the last case. So this is a 17-year-old girl from a village near Tumkur, comes from an agriculturist family, confluence of a history of itchy nose, eyes, and the sneezing since last 2 years. And symptoms are more in monsoon and winter months, and symptoms are more when she goes to field. So let's see what are the sensitization pattern that she has. So she seems to be quite sensitized to weed pollen here. So let's start knowing one by one. Are there any cross-reactive, allergens that we have got? So we have a Parthenium, then we have a Xanthium. So they both belong to a same family. So let's probably we will be keeping one only. Then we have Amaranthus also, Chenopodium also. So these two are from a different family, Amaranthaceae. So we can consider only one. And then the Ricinus does not cross-react with any of the other pollen. Now, so if this patient, if we have to consider for the immunotherapy also, probably one from each group is what we would consider. And you can also ask about whether, which pollen, and more of a, and among Parthenium and Xanthium, if I had to choose for this patient, probably I would choose more of a Xanthium. Also because from the reactivity, and as I said that, bit more towards the village and towards the agricultural land, there are a lot of Xanthium stomarium also along with Parthenium. So you can choose one among them depending on either exposure or the reactivity. So just to summarize, so in integrating whatever the knowledge of the aerobiology that we have into a clinical aerobiology, first is be familiar with the pollens that are there in your area of practice. Visit and revisit the history, and that is where what we tell it as in second history. Choose the allergens for immunotherapy, understanding on the patient's activity, patient's location, and also on the patient's near future plans. Understanding cross reactivity is crucial for selecting the allergens or narrowing down the allergens for allergen immunotherapy. So that's all that I had to share. I would be happy to take questions either now or at the end. Dr. Soundarya, how do we do that? You are
Hello,
muted.
ma'am. Thank you, ma'am, for such a lovely session. Actually, there's so much of learning in it. the importance of the second history that you emphasized, and the case is really, really enlightening. Thank you so much. I thought we'll finish the questions here. As of now, ma'am, the question I had, ma'am, was that is there any role when there is a major allergen and there are cross-reactive pollens? Because of having so much cross-reactivity, can the symptoms of the allergy be exacerbated? Like what could have been a simple oral allergy or a mild nasal itching? Can it actually progress to a full-blown allergic rhinitis just because the patient is in a place where there are lots of cross-reactive plants and he is exposed to lots of it?
Correct. Yes, it can be. It can be, as you know, that the allergy is like a quite a progressive, disorder. There can be progression of the symptoms too. But see, I will tell you. See, when I test here for amaranthus and the chenopodium both in Bangalore, patient do react for the chenopodium, but patient do not have an exposure of a chenopodium much too, right? So the amaranthus is what is still a predominant. So you might get a cross-reactive, in your test for the allergens which the patient also has not exposed because of the same kind of a protein which are common to. Okay, but if it is a
Oh.
clinically significant and having a many other co-sensitization, yes, it would attribute to the patient's symptom severity too.
Okay, thank you, ma'am. Just one more question. For the diagnosis, is it better to do a skin prick test or a component resolved diagnostic based test is better, ma'am?
For me, the skin prick allergy test remains still as an gold standard, and my clinical correlation, I always feel that the better. For a simple, the cases that which I have put mostly on in respiratory and the where the symptoms were either on allergic rhinitis, conjunctivitis, asthma, my the first test to go would definitely be skin prick allergy test and not CRD test. Okay, so CRD I would consider for the very other indications as in anaphylaxis or the exercise induced or for some specific food allergies, not for this at all.
Have you found
A little more
overlapping
history, you will be
process?
able to understand which allergen that you need to choose for allergen immunotherapy. It's not that difficult at all. And we are probably dealing with 14, 15 pollens at the max, not beyond that.
Thank you, ma'am. Ma'am, have you found any cross-reactive like between the fungal spores and the pollen spores as well?
Not really, actually. Not really.
Okay.
Not really. But
Okay,
within the
thank you.
fungi, there can be a bit of a
Yes,
cross reactivity too, within the fungi, but not with the fungi and the.
and the pollens and other things. Yes.
No.
Thank you, ma'am. Thank you so much for such a lovely session. Thank you so very much.
Thank you.
We
Thank you.
will now progress to our second talk. Our second talk is by Dr. Vikram Patra, renowned practicing pediatric allergist from Navi Mumbai. Sir will be speaking on allergy testing and aeroallergen panels, how to choose wisely. Dr. Vikram, over to you.
Thank you, Dr. Soundarya, for the nice introduction. I would like to thank Dr. Gayatri for making my job easy, because most of the things what she has spoken on, those are the things which makes the fundamental to how to select various tests. So may I request Dr. Gayatri to stop sharing her screen?
Is it still being shared?
Yeah.
Yes.
Oh, really? Did it stop now?
No, not yet.
No.
No?
Yeah, yeah.
Yes.
Thank you. Thank you.
Yeah.
Fine. Is it visible now, Dr. Sundari?
Yes, Dr. Vikram. All good.
Fine. So my job is to speak on allergy testing and to select aeroallergen panels. So what aeroallergen to be selected Already many of the things are covered by Dr. Gayatri, and today my topic will be integration of what we have been learning in last couple of days and today also. So I'll sum up everything, and we'll reach to the proper selection, a wise selection, which can make our diagnostic precision and immunotherapy outcomes will be better. So first question comes, why this question arises, why this topic first? So why choosing wisely matters in allergy diagnostics. So as we know, need not repeat, but 20 to 30% of Indians have allergic rhinitis and 15% approximately have asthma. And out of this, aeroallergen exposure is the major driver or the factor responsible for all these conditions. And now you all must be knowing there are various blood tests coming with various panels. There are indiscriminate panels, large number of allergens being tested. And remember, the more the number of tests, more are the chances of having false positive reports. So that will lead to misinterpretation and giving unnecessary allergen immunotherapy. So as we know, for success of immunotherapy, we need to have the right patient and the right allergen. So very beautifully, Dr. Gayatri has mentioned the selection of allergen for immunotherapy. But if we come across various false positive reports, we will not be able to select the right allergen. Then once we get all those multiple or polysensitized patients, then the clinical relevance is often poorly considered. Hardly many of us they go for a second history. So, and then the next question is, you may land up into a thing which is called as true sensitization versus cross reactivity. Must be, and this is very much important to decide on the allergen immunotherapy. And in other countries, you may have grass mix, you may have tree mix allergens for testing as well as for immunotherapy. In India, we cannot do that. Allergens vary drastically by ecological zones, so we don't have any universal Indian panel which is there, which can be applied for a North Indian patient or even a South Indian patient. So what are the principles when we select an allergy testing? First of all, history is very important. So most of the diagnosis will be done by clinical history, the main history, then the second history. And first of all, the history should be suggestive of IG mediated disease and not just to do screening, we should go for allergy testing. Then once we are sure, then we have to target the suspected triggers. And always we should start with a skin prick test, that is still that is the gold standard in diagnosing. Or if not possible, we will go for extract IgE. Then if required, if feasible, I'm not promoting component resolved diagnosis over here. There are very few indication in aeroallergen where we need to go for CRD. Otherwise, we have to restrict ourselves for clinical history and extract based diagnosis. Then always consider the regional aeroallergen profile, and this support shared decision making for AIT planning. So testing should not involve large indiscriminate panels. Be it be skin prick test or be it be extract based IgE test, it should not be a large indiscriminate panels. Yaki, this molecular allergology diagnostic workup, which talks about component resolved diagnosis, but you can see the first step is the individual history, the clinical symptoms, the clinical findings. Then you have skin prick test and extract based test like IG. Later on, if needed, CRD, but history stays important, plays important role. Why? Because we can get various clue from the history itself, what to do and which allergen to be selected. Now, detailed allergy history, carefully eliciting the symptom pattern, the timing. You must have observed in the Dr. Gayatri's various cases, every time she was mentioning about the time of symptoms, during what period of the day the patient is having those symptoms. Then we have to talk about the severity, then whether it is indoor or outdoor, and then the seasonality, whether the symptoms are seasonal or perennial trends, where we need to understand. Then certain aggravating factors like having pets, molds at home, and occupation we need to ask. Then the pattern recognition like seasonal sneezing suggests pollen allergy. Year-round symptoms with dust exposure suggest mites. But sometimes this dust mites also, they can have perennial symptoms, maybe milder, which many a times patients may unnotice, and they can have seasonal post-monsoon exuberation. So remember this point, and animal exposure hints at pet dander. So guided test selection, it has to be choose the skin or the IG test based on all these clinical clues and do not order the large panels. Minimize the test. As I mentioned, more the number of tests, more the chances of getting confused. The confusion is more, false positivity is more. So use adjuncts like from the history if you are not getting, having images of the flora around the place, maintaining a symptom diary, visual analog scales. All these tools will definitely help in finding or pinpointing the triggers before testing. So we need to understand the pre-test probability before jumping onto any test. Then the problem is aeroallergen exposure in India is a complex landscape because of this varied geographical this thing. We have various around approximately 12 major agroclimatic zones, and so they have all different pollination cycles. We have mountains, we have coastal areas, we have tropical, we have arid zones like Rajasthan, Gujarat, and a few places of Punjab. So local vegetation changes not only by the region, but also in the same place, in the same coastal areas. Mumbai will have different pollination, whereas the interior part of the Konkan will have some different pollination because it is affected by urbanization, pollution, and certain invasive species. They can change the flora. And on top of that, pollution can increase pollen allergenicity. The same pollen being found in the village area may not cause severe symptoms, whereas in the urban area it may cause more severe symptoms. So reason wise, now we have different pollen studies across our country. Around 12 pollen studies have been done till now. From North India, we have data for Delhi, Chandigarh, Lucknow. There, the major allergens found among trees is Holoptelia morus. Morus is a mulberry tree. In the recent 2021 article, which was published from the Chandigarh, they found that mulberry is one of the major aeroallergen. Then weeds, Canopodium amaranthus group, Artemisia, cannabis, and grasses are all everywhere. Cynodon will be seen in our country, in the our country. Then in the west, central India, we have data from Mumbai, Pune, Nagpur, and Aurangabad. Weeds, Parthenium again is the common. As Dr. Gayatri also mentioned, in the South India, we can get Parthenium more. Even in Maharashtra also, we get Parthenium more. Among trees, Ricinus, Elanthus, and high grass abundance, again the cynodon is going to be common. In South India, trees like Casuarina, Eucalyptus, Cocos. In among weeds, we have Parthenium, perennial grass exposure. East and Northeast, we have data from Kolkata and Guwahati. There, Trema orientalis, Mangifera, and among weeds, again Canopodium and Xanthium is important, and grasses, Poaceae group, again the cynodon. So major aeroallergens in India, as we say, we have to select very few allergens, not more than 10, 12. So we can select from these. Dominant tree pollens, we have Holoptelia, Prosopis, Elanthus, Morus. So what we commonly get is Holoptelia and Prosopis over here. Then among weed, we have Parthenium, Amaranthus, Chenopodium, and we can have Xanthium, then grass pollens, Cynodon, Sancrus, and Penicetum. So they also cross-react with each. Even if you go for only Cynodon, also it's sufficient. So this is a very busy slide where different pollination season, the spring, Feb to April, autumn, September to October, and winter, November to January. The different grasses, weeds, and trees species are mentioned. So you can click this screenshot of this, or you will get this. Now, geography and seasonal aerobiology map. This we need to understand because the cases you may get from different parts of our country. Now, as already discussed, during spring, the season is dominated by tree pollens, whereas a double peak will be seen around late summer or during the fall. Grasses and weeds come monsoon and post monsoon. Molds and dust mites tends to increase during humid monsoons and indoor confinement. Always use local calendars. Emerging city specific pollen calendars are there. Aerobiology data can guide clinicians. There are at present 12 pollen calendars from different states which are available with CSIR publication. And our IAP website also have started showing pollen calendars which are being contributed by Dr. Narmada. So this is a screenshot of our website where we have described the various pollens, pollen calendar in our country. Then comes after history taking, considering the clues, clinical clues, and the taking into account the geography of our area, we go for skin prick test. In skin prick test, need not repeat. We know when to do. It has to be done before taking any treatment decision. And there are certain contraindications we know in recent anaphylaxis or ongoing beta blocker therapy is a relative contraindication, uncontrolled severe asthma. These are all relative contraindication. And never do skin prick test if from the history, if you are getting that these are not IG mediated condition. Strength, highly specific and has got an excellent negative predictive value. Means if you are doing test and if the test is showing negative, then you can confidently say that the patient is not sensitized to whatever allergen you tested. But it has got a poor positive predictive value. That means what? Even if it comes positive, it need not be a true sensitization. So many a time the cross reactivity, the profilins and all these things can be there. And when you ask patient, you may not get clinical correlation. So that is the poor positive predictive value. So, and we have serum specific IG as an option where we cannot do skin prick test. Then the second choice is to go for serum specific IG. Again, we should not order any panel over here from the history, from the local geographic area. Select those pollens only when we are ordering serum specific IG. Otherwise, you will end up spending patients' money to the extent of 7,000 to 20,000. Now, if the patient cannot stop antihistamines, dermatographism is there, severe eczema, you cannot have site for doing SPT, then in those conditions, you need to go for serum-specific IgE. Coming to component result diagnosis, why it matters? Now, many a time, as I mentioned, the positive predictive value is low, be it be serum-specific IgE or be it be skin prick test. So if our clinical correlation is not matching, and if there are polysensitizations, then in certain conditions you may get, like suppose you are getting grass, you are getting weeds. Many a times they pollinate during the same season, but maybe the profilin which is there is responsible for positivity for both grass as well as weed. So in that case, CID may help in selecting only the weed, not the grass, for immunotherapy. So the advantages, it can identify genuine sensitization. It increases the accuracy of allergen immunotherapy, predicts severity, and clarifies a complex polysensitized profile. But here I would like to say we should not jump directly for component result diagnosis. And before we do component result diagnosis, we should be thorough in our knowledge in interpreting component result diagnostic CISCA reports. Now, coming to cross reactivity with true polysensitization, patients may test positive to multiple allergens, as I mentioned, grass, trees, and weeds. And sometimes they may be like if you are doing amaranthus and quinoa, both belongs to the same family, so they can come positive. It is the same family, but unrelated species also they can come positive. Like we get it in dust mites, cockroaches, and shrimps. So that those are called as pan allergens, and like tropomycin profilins. So already I mentioned. So these are responsible for various false polysensitization cases. But true polysensitization, this means genuine independent sensitization to more than two unrelated allergen sources with a strong clinical correlation. Now, grass CRD for India, we have Synodon. So when we do those multiplex, we have only one SynD1 over here. We have all this PHL, P1, these are Flippy 1, Flippy 2, Flippy 5, Flippy 7. These are all Timothy grass. These are for temperate climates. In our tropical, subtropical areas, we don't get all those things. But if pan allergens are positive, if you by mistake come across a report of CRD, and if on skin prick test, if you are getting grass as positive, and your Flippy 7 is positive on CRD, then you may not select grass because maybe this profilin is only responsible for cyanodon also. Now, weed CRD, we have ambrosia, artemisia, V1. These are the major marker allergens. Now, this is what Dr. Gayatri was telling. This is a classical image of the family. This is this ambrosia, artemisia, parthenium. This belong to this sunflower or the what you call it as Asteraceae group. So Parthenium, Artemisia, and Ambrosia. Whereas in Urticaceae group, you have that wall pellitory, which is even our Indian Holoptelia belongs to this Urticaceae group. Then the last is the Amaranthacea group. We have Kino, Amaranthus, and unfortunately, Kino and Amaranthus are not there in the CRD. So that's why we should not go for CRD in pollen because many of our Indian pollens are not covered. And many a times you come across this Russian thistle coming as positive. And if the patient may belong to Chennai. So generally, this Russian thistle is not there in our country, and still you are getting positive on the CRD because of this cross reactivity, because of the amaranthus. So if you are getting Russian thistle, you should get positive skin prick test report for amaranthus group. So practical panel selection tips where we have resource limited in the sense we don't have standardized allergens, we cannot go for CRD every time. Then always prioritize based on the prevalence. Start with the most common local allergens like most of us what we get is the house dust mites from the clinical symptoms we are going to get. So house dust mites, cockroach, a representative grass or weed from that family, and a few prevalent tree pollens should be done. Now, when you order skin prick test, they will give you a list of so many pollens, so many weeds, so many trees. Always order which are there around your place. So history is the important when you are, and if you are thorough with your history, then you can limit allergens. So if there are no exposure to pets, you should not go for pet testing. Then, so in a brief, if I can highlight the starter panel in a primary care or low resource clinic, consider basic 8 to 10 allergen screen like house dust mites, cockroach, grass, you select the cyanodon, weed, parthenium is common everywhere. You can select amaranthus from North India places, molds, aspergillus, alternaria, and cladosporium, and pen dander only if warranted. So the main tagline should be test less but test right, because better to test a few relevant allergy and always look at the pre-test probability before jumping for the test. Avoiding over testing and misinterpretation. So avoiding shotgun panels of 50 plus allergen in one go. Again, going to give more of false positive. And control is matter. Always ensure you are doing it properly with the skin prick test. Beware of these pan allergens. Always correlate with clinically and educate patients. Many a times, even if you are doing 10 to 12, many may come positive. So always go for the second history and educate patients that sensitization is not always allergy. So a short brief case just to select a patient from Delhi having symptoms February to May and August to October. Outdoor triggers are prominent. So what allergens you would go for? Trees, Holoptelia, Prosopis, Morus, Elenthus, weeds, Amaranthus, Parthenium, Kino, grasses, Cynodon and Sanctus also you can go, and house dust mites. So if a case is Bangalore, Mumbai, perennial symptoms are there, autumn worsening is there, I would select house dust mites because perennial symptoms are more. Then among grasses, Cynodon, weeds, I would select Parthenium. And among trees, if the patient is from Bangalore, Casuarina is commonly seen in Bangalore and Kerala area. So interpreting multipositivity, understanding patterns, we need to understand about these pen allergens. Many times because of this pen allergen, you can get polysensitization. High total Ig also can give rise to multiple this thing coming positive. Coarse sensitization due to simultaneous exposure, that is what is true sensitization. Now, AIT criteria for choosing wisely. So AIT is appropriate when symptoms correlate strongly with exposure pattern. Extract Ig plus clinical history and CRD confirm genuine sensitization, and allergen is regionally abundant. So if you come across a CRD which may have various pollens, But if that pollen is not belonging to your place, don't neglect that report. And poor control with pharmacotherapy, patient motivated and adherent, then only we go for AIT. When AIT is not appropriate, when only pan allergen is positive. So, for example, if I give, if a patient is positive for dust mites, cockroaches, and prawns, the patient may tell you that the patient has got severe urticaria or anaphylaxis after prawns and no respiratory. If I go for CRD, I may get derpy 10. So here I should not go for uh, allergen immunotherapy for house dust mites, even if the skin prick test is showing might to be positive. Then CRD guided AIT Nashik patient. Now here comes the role of CRD. One case I'll say, if the pollination is common, if the vegetation around are there, like for example Parthenium and Artemisia. So where in Maharashtra also we get Artemisia. So if the skin prick test has come positive for Parthenium as well as Artemisia, the CRD ambrosia A1 is negative, Artemisia V1 is negative. Now this ambrosia is also belongs to the same Astraceae group. Now all these two are from the same group. Now here ambrosia A1 Artemisia V1 negative, so I'll go for Parthenium here because that skin prick test is positive and these marker allergens are negative. But and we don't have Parthenium component in our CRD. Now, if Artemisia V1 is positive, then I will include Artemisia in my immunotherapy along with Parthenium. Because Parthenium is going to be there because it is ubiquitous. So, clinical outcome in this case, Parthenium AID was initiated and symptom improvement was found. So, this is a flowchart, ragweed and mugwort, both belonging to the same. So, skin prick test using ragweed pollen extract. If serum IgE for mugwort is positive and negative for ragweed, then it is a clear cut. It's a ragweed pollen allergy. You go for it is Artemisia. You go for Artemisia immunotherapy. But if both are positive, then we send for ambrosia A1, V1, V6. Then we found if both are positive, then we go for co-sensitization and we include both. And here, if mugwort is negative and ragweed is positive, we directly go for ragweed. So algorithm choosing the right test stepwise, again history, targeted SPT if multiple positive confusions, then only go for investigate with CRD. Identify primary sensitizers, determine clinical relevance, again that is what is going back to the history, and initiate immunotherapy with only genuine allergens. Avoid mixture of allergens in one vial. Now, little different topic. Now, you must have realized all these are difficult to interpret, to remember. So, can we take use of AI? Now, AI is coming in a big way in our medical field and in our allergy field also. So, these are the domains where AI is contributing. Aerobiology, so automated pollen ID. So, in India, high diversity under monitor regions are there. So, here it can help. Pollen forecasting, which Dr. Soibal sir is going to speak on. Climate, pollen pollution, this here AI can help us. Then CRD analysis, pattern analysis, cross reactivity clarifications, we can take help of AI. Then taking decision of immunotherapy, extract selection and response prediction can be predicted by AI. And in the clinical practice, decision support, digital symptom tools, urban pollution impact, all these things can be we can take help of AI over here. So how we can do? So the question comes: can we use AI for making ourselves better and rational allergy practitioner? Yes, for our thing, I showed you various domains, but for us, AI for pollen forecasting in Indian regions, AI in allergy diagnosis workflow, and AI in allergen immunotherapy planning. So how we can do that? So this is with my technical teams, my technical friends. I have come out with a allergen tool which can be accessed through your laptop or mobile. But remember, I should give a disclaimer over here. Always AI can do mistakes. They can hallucinate too. So there are chances of AI failures. So there is a famous saying from Stephen Hawking. Our future is a race between the growing power of technology and the wisdom with which we use it. And in no case, AI should win. Our human brain should be smarter than the AI brain. So for that, we should empower our brain. We have to go through the thorough literatures, then only interpretation. Because even if AI hallucinate, you should be able to pick that AI is there to help us and to make our job easy, not to guide us or not to train us. Remember. So then, if this is there, if we have a strong knowledge, AI will do wonders. So always human brain is always superior. We have been controlling big wild animals right from ancient days. Now we are controlling AI. Now coming to my tool. So because of the various reading various articles, I could formulate. It took me 3 months. So I'll give you what it tells. So when you are going for this thing, it will tell you about the taxonomy and allergen identity of that species, geographical distribution in our country, the pollination season, molecular and clinical cross reactivity, its clinical significance, particularly for our country. It helps in AIT decision making for that allergen, CID guidance if needed, and approach when CID is not feasible or available. And at the end, it gives high resolution images also. So summary key take points. India faces a high burden of allergic diseases due to aeroallergens. History is paramount. Use clinical clues to choose allergens for testing. Do not use broad default panels. Geography is the important thing to understand. Pollen calendars we should adapt in our clinical practice. Always distribute cross reactivity versus polysensitization. Resource wise testing, you should not unnecessarily waste patients' money. Test a limited set of likely allergens. Prioritize based on prevalence and patient history. Avoid over testing. Positive IG does not always mean true allergy. Interpret results in context and avoid false alarms. So I'll show you a live demo over here of my tool. So what it can, so these are basically, you can write name of your region. So just mention the name of your region. It will tell you what are the pollens around. So if I write Maharashtra, so if I just write, when you are talking with a AI model, you always give a long prompt. Here you need not give any prompt, just with words also it will catch. So you can see various studies, what I have fed it. So aeroallergens in Maharashtra, it has come, the pre-summer, the post-monsoon, the primary pollen allergens in Maharashtra. Then so different district wise also, whether rural, peri-urban, it has come out with. So likewise, so here I'll stop. And if the next thing what we can do, we can write individual allergen ring. So if I say about Ricinus communis, then I can mention about if on skin prick test, if multiple thing has come positive, you just mention the brief history and region, and with this positive, it will come with the great interpretation, which is true and which can be judged because of the cross reactivity, depending on the history as well as the skin positive report. These are the few things which we can do. And again, disclaimer, we should take help of these tools only to so here I just mentioned this, I didn't mention anything to him, just it showed various images it came out with, then the botanical and allergen identity, to what group it belongs to, then the geographical distribution in our country, then pollination season according to the different zones, then clinical relevant allergen components, then cross reactivity, to which all things it cross reacts, then clinical significance, then AIT consideration, so when CRD is not available, then what all things we can do. So this way it can help us. So here I'll stop. Thank you.
Thank you, Dr. Vikram. That was, I think, whatever questions I might have had, also you have answered as and how you have gone into your session. Thank you so much. That Indian Allergen Encyclopedia is really nice. How do we go into this? Like,
Please personal message me. I'll share. I'll
oh,
share. I
thank you.
will be happy to
Thank you
share
so much.
my tool with everyone.
Thank you so much because it's a very, very well needed requirement because we all belong to, I mean, looking at the speakers here, all of us belong to virtually all parts of India. So it's so nice to have something and the effort you put into, compile all this and get onto something which each of us can use. So thank you so much. I might most probably be the first person to message you after the session. Thank you so
Sure,
much,
sure.
Dr. Vikram. Thank you so much.
Thank you. Thank you.
With that, our last concluding session is by Dr. Saibal Moitra. Sir is an eminent immunologist, researcher from Apollo Multispecialty Hospitals in Kolkata. And today, Sir's topic will be on allergen forecasting, early warning systems, preventive policies, and with this, building allergy smart communities. Over to you, sir.
Yeah, thank you. At the outset, I would really like to thank Dr. Soundarya, Dr. Neeraj, entire the pediatric allergy chapter for organizing such informative and useful webinars for all of us in the country. It's really truly amazing and really hats off to all of you. Okay. So with this, so I have been given the task of talking on the aeroallergy forecasting, early warning systems, preventive policies, and building an allergy smart communities. Pretty futuristic topic, I thought, that Dr. Neeraj has given me, but very much needed. As you have just seen about the role of AI, Dr. Vikram Patra has just shared with us. With the previous two extremely beautiful talk by Dr. Gayatri Pandit and Dr. Vikram Patra, let me just build something upon them. Okay. At the outset, I would like to dedicate my talk to the stalwart of aerobiology, is Professor Sunil Malchanda. He was my mentor. Like I did my PhD under him, so he was my associate guide. He is the founder, president of the Indian Aerobiological Society, and also the past president of the International Aerobiological Society. He was a great palynologist, botanist, and aerobiologist. He was mainly trained in Germany, University in Göttingen, and then he spent a lot of time under Professor Ortmann in Sweden. So my entire talk is dedicated to him, who is no more in his mortal body, but he is omnipresent everywhere, wherever I am, or wherever there is any talk of the pollen grains. So the entire thing can be initiated with this two reports which I'm showing. So this was an article which was published in ATS, so a few years back. So it stated that pollen exposure and associated healthcare utilization. It was a population-based study, and this was mainly used health maintenance organization data in the Washington area. The conclusion was quite mind-boggling. this increased pollen exposure was associated with increases in healthcare utilization across a range of services, with relatively higher increases in provider calls, emails, and lower increases in emergent or acute care. If the climate change increases intensity and geographic scope of pollen exposure as predicted, and if the study's estimates of association of peak pollen exposure on healthcare utilization are generalizable, then the impact of change on healthcare utilization may be significant. So you see that this study already spoken and had sowed the seed of the pollen forecasting. That means if we can forecast or predict the high pollen seasons before, then actually we are doing a significant impact on the society, both on reducing the morbidity, to a certain extent mortality, and to a great extent the healthcare expenditure costs. In the same line, there was this the Gallen study, which was published in Allergy in 2014. It stated the same thing, but it had a very mind-boggling figure, So this was the economic burden of inadequate management of allergic diseases in European Union. They said, or they found out that inadequate allergen avoidance measures across the European Union, it caused an expenditure to the tune of 55 billion to 155 billion euro per annum. So can you see this figure? 155 billion euro per annum was the healthcare expenditure cost. So, and very, very important is a majority of this cost is preventable. Now, how do we prevent it? We prevent it by, of course, by avoiding the exposure. So this is a very interesting EPOCAL study. Okay, so the EPOCAL study, see if you can see that there is on the x-axis the individual relevant pollen exposures, and on the y-axis is a nasal ocular, that is a combined symptom medication scores, or it could be only the symptom scores. So that means it was done for the various pollens like the alder, ash, birch, and the grass season. Like if we take the red one, so as the exposure increased, the symptoms also increased and reached a plateau. And if it is only the symptom score, it also increased. We say plateau is somewhat declined, but majorly it is increased. So we see that with the increased exposure, there is increased in the symptom score, there's increased in the symptom medication score, and which translates into increased healthcare expenditure costs. So that means it is directly related that exposure, more morbidity, more healthcare cost. So we need to take care of this part, right? So we know that how do we treat? So there are 4 pillars of treatment of any aeroallergic disease. Number 1 is the allergen avoidance. Number 2 is obviously educating the patient. Number 4 is pharmacotherapy. And number 5, for the selected few, is immunotherapy. But out of this, if you see, I've highlighted this allergen avoidance. Very, very important. And we need to take a more bigger initiative on the allergen avoidance perspective, which has to be taken not on an individual base or individual scale, but on a large community and national scale. Okay, this is very important. That is going to reduce the burden of the suffering of the people of our country, and it is doing for all the countries as well. So if you just think of a roadmap for like allergy smart communities, so first of all, it starts with the aerobiological monitoring. That means we are monitoring the pollinating seasons, the sporing seasons, and we are seeing that how they are varying. But if you see in all this monitoring, so what do we do? So we are actually collecting the data, maybe the previous year data, or to certain extent a real-time data. So these are not any prediction of the futuristic, what is going to happen in the future. These are all in the past or to certain extent in the present. Even if you're doing a pollen counts, that means it is a 24-hour cycle if you're using, or a 7-day cycle. So you're collecting the pollens, then bringing to your lab, then counting it, then giving the data. So that means when you're actually studying it, the thing is in the past. Okay, so you are mostly dealing with the retrospective data. But this retrospective information has to be translated into forecasting models. Okay, so that we can forecast, like the weather forecast. We can forecast that what is going to happen maybe in the next winter, or maybe in the next year, maybe in the next summer, so that this can actually translate into what is the most important is a real-time warning systems. That means we uh, warn the public or the population beforehand. Say there is going to be a high pollen season at this time, so they can plan their movements. They can take some preventive medications, but they can change their lifestyle whatever way they want, so that they reduce the exposure to the allergens. And in that manner, they reduce the symptoms, reduce the usage of medication, reduce the morbidity, reduce the exercise observations. What all you talk of, it translates into that. So this is the roadmap. Now let us very slowly and steadily walk on this and see that how far we're able to move, we're able to go. So is number one, first is the evolution of the pollen and the phenological or the flowering for forecasting. So how it is being done, like either we have the old models, which is being means translated or given on the new regions. Like we have certain very good studies where the old forecasting models or the old phenological forecasting models have been translated on the Bavarian region in the Europe, and they have found very good results in that. Or created new models for a wider geographic areas. That is the talk of the day. Okay, because the majority of the areas, we do not have such models. We do not have such a model for India. Okay, but anyway, but the creating such models, and definitely it helps in evaluating this. So there were some of the initiating work which was started on the NIRI in the Nagpur, but I don't know that because it's not published, and I don't know how far they have moved ahead with that. And very, very important, to improve the time resolution of the forecasting. Like say, you can forecast it maybe, say if you can forecast it, say 4 months or earlier, or can you forecast it within 24 hours? Or can you forecast it within one hour? Like when we have the cyclones, okay, and the weather monitoring system can forecast that, yes, next week, this day, we are going to have such and such cyclones. Like recently, we have a cyclone just hit at the Tamil Nadu. So we know that this was forecasted. So time resolution of forecasting is very, very important, that with what precision and how much before we can forecast this. So this is how the entire thing has to be developed and modeled in to actually suit the particular need of the public. So for this, we need the real-time data. A real-time data in what aspects? These three aspects. Number one is the pollen and the spore counts that we talk of so much when we're talking the aerobiology. But at the same time, we need to have the meteorological data about the rainfall, about the temperature, about the photo period, about the wind speed, about the wind directions, and so about the means and the sunshine and so on and so forth. These are very, very important, okay, because that has a close impact on the flowering of the plants. That has a very important impact on the pollen production, its release, and its dispersal in the wind. So this has all been clubbed together to now we have a common composite indices, which we call a bioclimatic indices. And the third thing, in every modeling systems, now this has become very, very important, is to include the air pollution data. Because now we know that the air pollution, the various particulate matters, the ground level ozone, oxides of nitrogen, sulfur, ammonia, all this has an important impact on the pollination of the plants. Not only the pollination, but also the allergenicity of the pollens. So air pollution data needs to be amalgamated when there is a modeling of the forecasting of the entire pollens or the fungal spores is needed to be made for the future. Now, so this starts with the basic aspect. That is one main aspect that we talk about is the aeropulmonological monitoring. Okay. But there are certain problems with the aeropulmonological monitoring, that is a pollen monitoring. What are the problems? First is all the data are not freely available. You just tell me that how many pollen counting stations are there in the country. You can hardly count on fingers. Okay. If you just look around where you're staying and just try to find out there are how many pollen stations are there, the pollen traps are there, you will be amazed to see that it is so less or few. Majority of the cities do not have it. Okay. And some places where it is available, it is by private. They do not share the data. It is not freely available. There are many restrictions and not available for the public usage also. So this is a very big problem, that we do not have a very credible and good data with a good spatial and a temporal resolution. Okay. Another very important is no harmonization of the methods. Like one is collecting the data maybe on Burkhardt, another on Anderson, another on Durham's. But there is a lot of variation when it is collected by because there are the various methods. So until and unless there's harmonization of the various methods of the pollen count collection, it cannot be clubbed into a single model, and which actually becomes a very big problem in forecasting it for the future. So lack of stations, no harmonization of the methods for the pollen collection and counting. As I've said, only few stations are there, and continuous monitoring is lacking in all the stations. Whatever stations you have, they're operating only on certain period of the time when maybe some research work is going on, or maybe some student is doing some thesis or the dissertation or some project. It is not a continuous monitoring. So there is lack of continuous monitoring. These are the problems which I'm stating, and which is actually plaguing our country, India. Okay, so everything which I'm talking is in context of India. So these are the main problem which is there, and which is actually plaguing us. And we need to acknowledge these problems. So many a time, in many places, people are using a surrogate marker of this. Okay, you will find there are a few studies which have used a surrogate marker for these problems. Just like we use like blood eosinophils as a surrogate marker for the sputum eosinophils. Similarly, so this is a very clever thing to do. But I don't think it's very much applicable to the Indian population. Maybe the urban and Indian population may be applicable, but not to the semi-urban or the rural population. What is it that they have looked into the tweets or the Google Trends, that where they see that when is the time when the people are searching maximum with the keyword of the allergy, okay, or pollens. So when is happening maximum? So in what premise? The premise is that when the people are suffering from this, So they usually do more tweets, or they will have more Google Trends, and they will search in a Google search. They will search this words. Well, this was somewhat applicable in the epidemic situations, like we had it during the COVID. Okay, so we did a very interesting paper, and we wanted to see that what was the impact of the infodemic, that information we have, on the Google Trends, and also the psychological well-being of chronic respiratory diseases. And we found that it was quite high, but it do not apply to a regular monitoring as we need in case of the palynological or aeropalynological monitoring. So it has biases. Definitely it has biases, so it cannot be applied to a great extent. Now, do we have some solutions for all this? Well, we have some solutions for all this. Number one is that the use of statistical interpolation techniques, or the Kriging techniques. Okay, the Kriging technique is actually, say, if you have, say, pollen counting station somewhere, maybe in Kolkata you have. So I belong to East India, so let me speak about the Kolkata, the city I love. Okay, so it has a pollen collection station in Kolkata. So let us talk about a nearby district town in Kolkata. Say it is a maybe that is your Malda. Okay, so far there is no pollen stations. So whatever the data which is being captured by the pollen station in Kolkata, that is actually extrapolated to the region of the Malda by statistical interpolation techniques, which is called a Kriging technique. And multivariable Kriging, or the co-Kriging, this is very widely used, so not all over the world. This is a very common method. What they do is they take a covariable. Covariable is basically a parameter, say an altitude, okay, or maybe say a city with the similar level of sunshine, relative humidity, or nearness to the sea, whatever it is. So we'll take this covariable, and using this covariable of these parameters, which are comparable between the two places, they will extrapolate the data which is there from one of the place where this polling station is there to another place where polling station is not there. That is on the areas which do not have a regular pollen monitoring, extrapolating the data over there, and that is usually being done. This is a very robust and good statistical interpolation techniques, like the co-Kriging, which is used all over the world and can be used in India as well. And well, Dr. Vikram has said that, well, AI is now the game changer. Yeah, absolutely. So use of the convolutional neural networks, okay, it has been coming up in a big way, where it can actually do and extrapolate the data available from one of the areas to the other areas. And it is said it is much faster than the co-Kriging, so that you get the results much faster. Maybe efficacy-wise and accuracy-wise, it may be similar to co-Kriging, but it gives the data much faster. So maybe if we have the real-time data with automated networks, the use of convolutional neural networks definitely has an edge over the traditional co-Kriging method. So this is basically dependent upon having an automated pollen monitoring network. So nowadays, many places, they're moving towards not the manual counting machines like a Burkhardt and all, but they're moving towards like BA300 and all, that is the automated machines, or the automated pollen traps, where they're basically continuously and automatically they're counting. So one of the advantage of this, that you get the data more or less in the real time. It's not that past 24 hours or past 7 days, you collect it and bring it to the lab, then count it and then give it. No, it is happening at every hour. So this is an automated pollen collector. And there's an automated pollen collector or pollen monitoring network, they are actually working on the same principle. So there's harmonization of the method as well. And when this is put into the convolutional neural networks, they actually give a more rapid head monitoring data, which can be used later on. Or this is very interesting. Like, see, we all say that the here this is pollen and calendar. Initially, formation of pollen calendar. You usually do a ecofloristic survey. Okay, ecofloristic survey. That means you go around and you see that which is a flowering plant. As you have seen that Dr. Gayatri is so beautifully doing this. That is an ecofloristic survey. That is collecting a phenological data instead. Okay, so that means there may not be any pollen stations, but you can very well go around and collect the flowering data at which time of the year this plant is flowering. Then you study that what are the pollens and then when they come up, because you know that there's that with flowers only the pollen will come. And very important is the phenological data networks. They are much more dense all over the world, in India also. Okay, most of the college where there's a botany department, they will have there's the phenological data collection center. Okay, and so they collect the data, they share it among them. So it is much dense. So spatially, the density is much more. And nowadays, there have been a revolution in this flowering data collection by the use of the remote sensing. Okay, so in the remote sensing, what they do, they have the satellite or they have the unmanned aerial vehicles, which actually collect the high resolution images of the vegetations on the ground. Or they can have a multispectral or a hyperspectral image, or they also call it LIDAR data, that is a light density and ranging data. So by collecting this data, they usually form a spectral signature of the vegetations. And by keeping a spectral signature, so usually more or less there's a combination of the hyperspectral image and the LIDAR data. They create the spectral signature, and they can very accurately find out which plant is flowering when. So, and that data can be assimilated by what is called the data assimilation. So, and that becomes very important when and in the areas where there is a lot of vegetation, lot of diversity in the vegetations, as in the tropical countries, or maybe there's a density of the pollen is quite high when it's more than 50 grains per cubic millimeter, then this type of remote sensing comes to be of great help. So this all leads to now with that is the forecasting. Now for the forecasting of the aerobiological or the aeropalynological forecasting, they're mainly based on two models. That is, now also it is mainly these two models. One is an observation-based model and another is a process-based model. Now, the observation-based model is basically, it is also called an empiric model or a receptor-oriented models, because the data which is there for modeling is collected from the pollen traps, whether it is automated or it is manual. So it is a receptor which is receiving the pollens, and from there the data is collected. So it is an observation-based or receptor-oriented models. But in the process-based models, it is a simulation models. So that is mostly source-oriented. That is the source from where the pollen grains are coming. That is the flowers. Okay. So it is production of the pollens, the dispersal of the pollens, and the path that the pollen takes from the source till the pollen trap. Depending upon that, these models are formed. Okay. So let us see what are the few observation-based models we have. Very common is the calendar forecast. So that means we have that pollen calendar, and accordingly we find out that what is going to be there in the next uh, maybe the next year or the year after that. Only thing is, in the calendar forecast, what has to be amalgamated is the meteorological data or the bioclimatic indices, as I was talking before. So that has to be combined in the calendar forecast. Problem with the calendar forecast is the time resolution is poor in the calendar forecast. So after this assimilation of the meteorological and the calendar data or the pollen calendar data, usually go for regression and the correlation analysis and find out the correlation or the regression coefficients. But as I have said, that is the time at least the time resolution is quite poor in that. So now we have better the time series models. I won't go into detail. One is the Box-Jenkins method, which is an auto-regressive moving average method. This is a time series, most commonly used the time series method, where the data comes and we can measure in time that what is going to happen in the next 24 hours or next 1 month and things like that. But again, here, the computational intelligence is the turning point. And here also, the use of multiple machine learning models has been very, very important, because you know that the pollen grains, there's a lot of randomness in the pollen grain, right? It's not that a pollen grain will follow a discrete path and will go and stick on the say the human mucosa. No, it is just going to be random. There's this chaotic component in the pollen path. So that can be covered not by the models that we have calendar forecast models or the ARMA model. That can be done by machine learning models. Like you have the neural networks, or you have the random forest. Okay. Nowadays the fuzzy based methods are actually means it is being compounded with the neural network, so that you have the neurofuzzy models. This give much more accurate detailing about the pollen forecast in the future. So especially when the high pollen counts are there, then this is also becomes very useful. Another interesting thing is that with all the models that I've talked so far, it will determine that, well, it is going to be the count, and this is in the next season, and next year, in the next season, this is that. These are all called deterministic models. But this is a very interesting, a hidden Markov model. It is a stochastic model. What is stochastic model means what? It is basically a mathematical model where it gives a probability distribution of the all possible outcomes. Okay, it's a probability distribution model. So that means it is not a particular outcome. It can be various outcomes. That means the various concentrations which can be found in next year in the same time. This is given by this hidden Markov model, this observation-based model, and this has been shown to be superior than the other deterministic models that I have talked so far. Well, what are the process-based models? As I've said, the process-based models, it takes into account on the pollen production and its transport through the air into the pollen trap. So it could be based on the flowering models or the phenological models, or what we'll call a bud burst models. So that is when there's a chilling temperature when the bud is formed, and the temperature when it bursts. So these are very important. So now what is the time when a plant enters this flowering season, when it goes into a flowering phase? That is very important. In temperate areas, it is usually the temperature which determines, but in countries like India or the Mediterranean regions, it is the rainfall and the photoperiod or the daylight, which determines that when a plant would go into a flowering phase. And that is very important, because that helps to decide that whether it is changing with every passing year or is the same. So, or we can have a pollen dispersal models. The pollen dispersal models is basically, it takes into account the dispersal of the pollen through the air, through the atmosphere. And we can understand that dispersal of the pollen grains, it is impacted by various other factors, meteorological factors, as I've just talked about: wind speed, wind direction, temperature, rainfall. All these things matters. And nowadays, even the air pollution matters. Okay, so these are all the things. So depending upon that, so you can have this something like a Eulerian model. So I'll just tell you what is this. Just giving you a concept of what is a Eulerian model. Is basically here the pollen grains, they're considered as actually all these models are used in the pollution in the weather forecasting, but they have been applied in the aerobiological forecasting as well. So the Eulerian model, what it considers is that the pollen grains are taken as a continuum, okay, and the concentration filled in a particular grid of that continuum, which is fixed in time and space, is evaluated over a period of time. That is the Eulerian model. So the Eulerian model is basically a more comprehensive and more conservative models, okay. Or they can be a Lagrangian model. In a Lagrangian model, basically they say that the pollen particles are taken as a discrete particles, and its movement over an atmospheric continuum is taken into fact of the modeling. So this is, or maybe some multimodal ensemble, like you have this Copernicus, this automated machine. And so answers which it comes for forecast as it is a multimodal ensemble. But whatever it is being done, very, very important is to have a data elimination of the emission of the flowers. That is a phenological emission, because with this data elimination, it gives the important and actually the information about when the flowering is occurring, and when and it is basically going to have an impact in for the human beings. And for that, we can have a like short time forecasting, the seasonal forecasting, or a long-term forecasting. The most common is seasonal forecasting. Short-term forecasting usually we need during the time of high pollen and seasons, when day-to-day variations of the pollen levels or the spore levels can be forecasted. Seasonal forecasting is basically in the particular seasonal variations, and long-term forecasting, where we know that in the next 5 years what is going to happen. So they take into account the various drifts and the shifts in the meteorological factors, and then a big past data of around 20 years data is needed so that they can do the long-term for forecasting. But whatever models that is being used, so what is the efficiency of that models? Because before we model it and we apply it, and to the public, we need to know what is the forecasting skills, and which will help us to know the allergy risk assessment for the patient, because we need to talk in perspective of the patient, no? So one is that the correlation of the pollen load with the daily symptom records. Now we have multiple apps like the area, mask care, allergy diary, so which actually can correlate with the pollen load and the symptom diary. We can know that this model, which has shown that this is the predicted pollen load maybe the next month. So what is the allergy diary app is saying, whether symptoms are increasing or symptoms are remaining the same. So this helps us in estimating the model performance, whether it is performing well, because if it does not, then whatever it is a computational intelligence, or whether it is a Eulerian or Lagrangian, or it is some observation-based model, but it has to perform. So this risk assessment is done by probabilistic skill-based and threshold-based statistics. Usually this actually finds out that whatever has been predicted and whatever has been observed, so how much they actually align with each other. That is the accuracy of the forecasting models or the forecasting skills. It is said that model should have a high probability of diagnosis. Okay, that means it can diagnose. It has diagnosed that this is the pollen levels would be high, maybe on January 31st, and it actually happened. And GS stands for JRT score. So what is a JRT score? JRT score is basically the scoring system which is achieved by giving weight to the individual wrong decisions which the model has made, depending upon how wrong they are from the predicted values. So this is the JRT score. So you said the model should have a high probability of detection and a JRT score and a low false alarm rate, that is FAR, the clinical significance, and to be given to the public. So every model has to pass this test. Okay, so this is the test which has to pass, and it varies with the various climatic conditions. Okay, like we say that normally and the Eulerian method of this of the modeling is more widely used. But maybe in the areas where their shifts in the wind movements are quite unpredictable, there the Lagrangian method of modeling is more useful, like in the mountains. Okay, so there maybe the Lagrangian would be more fit. It would have a high POD and a high JRT score or than the Eulerian model. So this translates into the public dissemination. So how effectively we are able to give this information to the public so that can have the early warning systems in place. So whether it's a newspaper, television, website, smartphone apps. So this is very, very important that the aerobiology networks, it need to provide time and spatial resolved forecast. Spatial means that means of all the areas it can cover, and time means with the time, that is the future. That is 1 day, 2 day, 3 day, 1 hour, 2 hour. This is very important. So we have some very good sites like for the polleninfo.com, pollen.com, or pollen forecast. That is in the Australia, the US, and the Europe. Or we can have the information in an entirely new format. New format means we give the information that at this particular season, this is going to be the pollen load, and it can cause these symptoms to the susceptible individuals. Like this is done in this site, that is a Dagins for pollen telling you. Okay, so this is very important. Just early warning systems we have in the US at the Weather Channel, or we have in Australia the OzPollen project. This actually gives a very early warning systems which can actually alert the individual so that the exposure is reduced. They can plan the activity beforehand so that there's reduction in the morbidity. So this is just a schematic diagram of an allergy smart community based on all what I have talked so far. So you can see that these are the houses, these are buildings. So we have a satellite vegetation phenology monitoring, which is by the remote sensing satellite pictures, taking into account the climate change and the urbanization. We have the meteorological data. We have the pollen allergy and the human health data from the mHealth app, the various apps. We have the pollen counts and the concentration and data, which is coming from the automated networks or maybe the manual pollen counters. And we have the plant phenology data, which also can be taken either by doing ecofloristic survey, that's a ground level survey, or by the remote sensors using a hyperspectral image with the LIDAR data. And there's a geospatial big data. So why it is called big data? Because they are going to handle a lot of data from the perspective of the human health and lot of data on the perspective of the meteorological data and the climate change. So this big data handling has to be done by using the AI, and this can actually form a community where they can inform before that what is going to happen in the future. And this actually makes everyone a very allergy smart community. So if you look into the conclusion, it is basically the pollen forecasting. It actually conjugates the aerobiology, the engineering, the physics, and informatics. All has to be taken together while we are working in this field. So observation-based models are still widely used. We see the calendar forecast are still something, but though it has a very poor time resolution, but the newer models use of the AI, and it is coming up. So, and the process-based models are more suited to capture the long distance dispersal events, because you know that 90% of the pollens, they affect the individual, so 100 meters to around 27 kilometers. Okay, but more than that, that is several kilometers. And because when the wind speed is high, so for the long distance dispersal, for the poles which are very high, here the process-based models, they are more suited than the observation-based models. And the use of the M-Health or the E-Health incorporating pollen data will help patients residing in the remote areas where they may not have access to everything, and use of as I've said, that the various modeling systems and the multivariate co-kriging, it actually helps to have the data in those areas where there are no pollen stations, maybe some remote areas, rural areas, and so on and so forth. But very important, reliability of all the apps is still questionable with respect to pollen forecasting, because we need to know what is the POD, the probability of detection, and the Grady score of each and individual models, which no one gives. Okay, if you do not have that, you cannot actually just take like that, and there's a questionable question on the veracity of these modeling systems. Okay, thank you very much. And this is the picture of my institute, but where I did my PhD and my aerobiology training and everything. So there is the Bose Institute in the Kolkata, a century-old institute, which was started by a very famous scientist, Jagdish Chandra Bose. So this is the heritage building of the Bose Institute. And I really, my sincere gratitude to Professor Shati Gupta Bhattacharya, Professor Kashna Bhattacharya, who were the head of the department. They did a hand holding for me, and they helped me learn how to do a pollen counts, how to do what is aerobiology. So my all the aerobiology for the exercise and learning, along with my mentor, they were by my side and helped me to understand this topic much better. And though I have to learn a lot in this, as you can see, that is the evolving field. Thank you very much.
Thank you, Dr. Saibal. When I listen to your talk, I am constantly reminded that I am going to remain a lifelong learner like this, because there
We
is
all are.
so
We all are.
in that I seem to be well at the starting.
Not
It
like
was
that.
a very interesting talk. So thank you so much. Very interesting, because when I even went to the Mangalore University here and asked exactly the botany department what you were telling about the pollen counters, and it seems so interesting. But a lot needs to be done. Lot needs to be done. There is not much. As much as you have spoken, we are way not even near the starting point. So thank you, sir. Thank you so much for that absolutely lovely talk. Thank you. Dr. Neeraj, any concluding remarks from you, sir?
I think so. Before the start of aerobiology webinar series or clinical aerobiology webinar series, so we all used to think that this seems to be more like a dry topic, and probably we need not to know much about the things, and we don't know many things, something like that. But past 3 days, they have been really phenomenal, in which we have really started with, you can say, like in a systematic manner, how we have opened up layer by layer all those things. And then after, you can say, like at the fog end, when we were thinking that okay, we have now learned something, Dr. Sabel came and he told that you don't know anything. So means like I'm really wondering what actually happened in past 3 days. It means it started from zero, and now it once again ending up in a, you can say, like much more vacated space, much more this thing. Means I must appreciate, and I for Dr. Sabel's dedication. Means like I'm not saying it on the forum, but this is personal feeling which I always feel, that his dedication to particular subject, to particular science, to innovation, that whatsoever you give him the topic, uh, he always go, you can say, like 10 miles deeper into that particular subject, and he actually shows us the way. So he is, I think he is the true pioneer, true leader for myself, who actually shows the way. And the quality of leader is something like he's doing the things, and then he's showing how to do it. And the way he is showing means, like, even when I have allocated this topic to him, I was not knowing that what he's going to speak. And I just told him that I know that you will do something, but I was not knowing what he will do. But now whatever he has produced this, so means like I don't know what to say now. So anyway, thank you so much, Dr. Sabal sir. Thank you so much, Dr. Vikram. I think Dr. Vikram has done a fantastic job. He is the person who works more behind the curtains.
Yeah, that
For past
Indian
one
allergy
year,
encyclopedia is fantastic. I think we all will need that.
past 1 year he has actually worked behind the curtains, and I know him so well, that he is such a gentleman, such a gentle person, working so hard behind the curtains each and every time. He never ask his name in front. He is just doing the work, passing on to me, and then he always say that you put it on the groups. Means like he always means like he never show that he has actually done this work. So I have been really lucky to, you can say, like, have this type of a group, this type of a family, that where we all were able to do. So I think this was the last webinar series for this year 2025, and probably for my tenure also this will be the last webinar series. And after that we might be having, if you want 2 or 3 more webinars, that might be possible. But otherwise I think we are now done with the job. And I am very happy that now, and feeling much relieved that I will be now passing on the torch to the next person. But thank you very much for this very successful, very happy 2025, uh, for the allergy specialty, allergy subject. And thank you so much. Thank you.
Dr. Soundarya, do you believe what Dr. Neeraj just say? This is over 1 month still there. I think one more than 1 month.
No, I'm saying 2025 last series.
So,
I said 2025 last series.
that has been
That,
very
that,
cautious.
that 1 month is
2025
26.
for last.
That 1 month is in 26, not in 25.
That's a good relieving point.
Anyway, I have not. I have said that I have just done for the means like as a webinar series for the chapter, but I have not said that I have done for the specialty. I will be continuing to work in the specialty. That's
You are meant for that.
yeah, means
Exactly, sir.
I actually
Absolutely.
enjoy that. So by somehow or other, I will just continue working in this specialty. I will try to find the ways how to do that. But thank you so much. Thank you. So,
Thank you,
and
sir. Thank
wonderful
you so much.
moderation once again by Dr. Sundarya. So I always give the toughest moderation, the toughest speakers, the
I,
toughest topics,
I
and
am
toughest
beginning to
moderation to Sundarya only. So
after after Gayatri ma'am's talk only, I thought, wow, I have reached this level. After Vikram's talk, I got, oh God, this only so much more is there. After Cyber's talk, I have decided that, oh no, I don't know anything now. Knowledge brings doubt means this is what it has brought me, complete doubt now.
so Dr. Saban is from different world actually. So we all
Different level
that we
altogether.
he is
No,
such a
no, no.
noble
Yeah.
person that he actually means like I always feel lucky that I actually know him and he actually knows me. So that's something good for me, and this I
I,
always feel
the-
from my heart.
I feel lucky that I know all of you. So nice
This is true
people, and
humbleness of
I
him. This is
really
true
love all
humbleness
of
of him.
you.
So this is, there are some things which
So
we
sweet
need
of
not
you.
to hear from
Thank
him.
you.
So this last thing we will just omit from his statement. Anyway, thank you everyone.
Thank
Thank
you,
you.
sir. Thank
Thank
you. Thank
you.
you, sir.